Good morning, Internet world. This is Dolly England, the Reproductive Health Access Coordinator with the Reproductive Health Program, and we are very excited to be bringing you yet another PE46 webinar. Because we have a very full agenda for today, I am not going to wait anymore, and we are going to go ahead and start this party. All right, so our agenda for today is we will do some welcome introductions. We will do everything PE46. We're going to do some general updates, and we're going to lean right into our topic for today, talking about the HPV vaccine with our guest speaker, Dr. Stuart Decker. So during today's webinar, we will be doing live polling, and we encourage you to participate in our live polling. In order to participate, all you have to do is text RH program to 22333, or you can participate via the web by going to pollev.com/RH program. This is what it's going to look like. You'll text 22333 to RH program, or rather other way around, and it's going to send you a link to the website. So you're going to answer the questions via the web. This is what it'll look like on our screen. So you will ask a simple question, what's your favorite color? You're going to respond. So you might respond with the letter that you want to use. Yellow is C. Again, I'm going to leave this up just for a second to make sure that everyone has logged in. You are going to text RH program to 22333, or you're going to log on from the web, pollev.com/RH program. Okay, let us practice, shall we? In one word, what county do you represent? In one word, what county do you represent? All right, people are participating. Washington just got giant, which means there's a lot of people from Washington County, Marion counties, the state, which probably means state employees. Hello, we see you. Clatsop, Lynn, Klamath, Jefferson, Baker, Josephine, Harney, Clackamas, Umatilla. We see you. We see you, y'all. Okay, I'm going to leave this up for just a second to let folks who are just joining us join in our fun poll activities, which we will be doing all day, or rather during this webinar. You're going to text RH program to 22333. Again, that's RH program to 22333. So it definitely seems there are quite a few people on here from Washington County, Marion, Baker, Clackamas are all pretty big. That means there are a lot of people participating from those counties. All right, let's go to the next one, shall we? All right. Would you rather have all traffic lights you approach be green, or never have to stand in line again? Would you rather have all traffic lights you approach be green, or never have to stand in line again? So it appears that people are really not trying to stand in lines, which I get. I personally spend most of my time in a car commuting, so I would have to go with the green light, with these green light folks. So you can see these are going to be fun. You're going to want to participate. Let's get to the next poll. Why did you decide to join this webinar today? A, knowledge building. B, the speaker lineup. C, networking opportunities. Or D, my boss made me. Somebody's boss made them. Okay. But looks like most of y'all are really interested in building your knowledge, and you're excited about our speaker today, which is excellent. All right, let's skip on to that next one, shall we? I do work around A, reproductive health, B, immunizations, or C, I'm a rock star, I do both? Well, it appears we have some rock stars. We've got a good amount of people that are doing RH services and a good amount of people that are doing immunization services. Excellent. And it looks like we've got a lot of rock stars that are doing both work. Excellent. All right, let's do the next poll. I work for A, local public health, B, a clinic, C, a hospital, D, a community-based organization, or E, a government agency. Look like local public health is in the house representing. But it looks like we have some clinic and hospital staff also participating, as well as a number of government agency employees. Excellent. All right, next poll. Do you know how to find an RH clinic? Do you know how to find a reproductive health clinic? Yes or no? Do you know how to find a reproductive health clinic? So it seems that a good amount of people do know how to find an RH clinic. However, there is a good amount of people that do not know how to find an RH clinic. All right, let's go to the next poll, shall we? As a non-RH, that's reproductive health clinical provider, I know how to partner with RH clinics. So as a non-reproductive health clinical provider, I know how to partner with reproductive health clinics. Yes, no, or maybe. So for those of you that are joining us on the line today at PE46 folks, we are partnering with the state immunization program. We have a number of immunization providers on today's webinar in addition to reproductive health providers. And so we're trying to figure out what you know about each other. And it looks like non-clinical providers do, for the most part, know how to partner with RH clinics. However, there's a good amount of people that do not. So my next question, if you are a non-RH clinic, do you know how to refer to a RH clinic? Yes or no? If you are a non-RH clinic, do you know how to refer to a RH clinic? Yes or no? So it's a good half and half. Real interesting for us. We've got work to do. Okay. So here's the answer to your question. If you do not know how to refer to a reproductive health clinic, here is the link. You can go to healthoregon.org/RH clinics. You can enter your zip code and it'll tell you all of the clinics that are nearest to you. We encourage you to do that. And these slides will be available after the webinar, as well as this webinar is going to be recorded. So I'm going to quickly go through everything PE46. This is really content targeted at PE46 providers on this line. Upcoming webinar, just a reminder that our December webinar is around reproductive health outreach and education. Our January webinar will be the Local Public Health Authority Roundtable, where you are going to talk to us about what you are doing with PE46. Please note that this is, it is expected that all LPHAs are going to participate in the January PE46 webinar. I have sent out emails, but I will resend out what we are looking for, including a slide deck. We want you to focus on what you've been doing and what your plan is for 2019-2020. We want to know what you've done, what your next steps are, any challenges, things you're proud of, what you want to know from other counties. So we look forward to seeing your presentations. As a reminder, your PowerPoint slides will be due Friday, January the 17th. Feel free to email them to me directly. And as a note, it is expected that each county will participate in the January PE46 webinar. As always, I'm available for technical assistance, and I'm really fun and love chatting on the phone. So feel free to hit me up. We can schedule time. We can talk about your work. I'm happy to be there for you. Just want to do a quick shout out to those that participated in our reproductive health coordinators meeting. We had a real fun time. Just want to shout out to all the people that used my photo booth. Really appreciate you. We had so much fun, and it was really nice for me to meet some of you face to face that I haven't yet had the opportunity to meet. Just a friendly reminder that the RH program is on social media. So that's right, you can follow us on Instagram at Oregon CCare, as well as on Facebook. If you have something cool happening that you're sharing on social media, please let us know. The RH program would love to share more content from our partners. All right, it's time for Dolly's community engagement moment. And for those of you that are new to this webinar, I try to share some sort of outreach moment from my own personal life. And this month will be that one time I had a newspaper column. Because I don't know why, other than my name's Dolly, that it was called Hello Dolly, because what else would I have called it? But I would mostly write an article about a different sexual or reproductive health topic every month in a local newspaper in the community that I was living in. And as it turns out, there was a month that I actually wrote my topic on HPV. And so what I did was I wanted to just fast forward to today. And first of all, note the date on this article. A lot has changed in the last 12 years. Some things that I thought was interesting, HPV can be transmitted by intimate skin-to-skin contact, even if the person isn't engaging in sex, according to their definition. So here in the blue, I mentioned that virgins are getting HPV, and young girls are playing with Malibu Barbie, but they aren't necessarily having sex. That was my point. But what we know now is that some cases may also be attributed to transmission at birth. Some research shows that some infants born to women who were positive for HPV during pregnancy test positive for HPV. Most of these infections are cleared by the infant's immune system, but some cases may become persistent HPV infections. There's lots that are still unknown about risk and magnitude of these types of transmissions. So it's still true that most cases are caused by skin-to-skin contact. We also get smarter, though. So HPV causes many cancers in people of all genders, not just cervical cancer. It can cause cancers of the cervix, vagina, vulva, anus, rectum, and oropharynx.
Oropharyngeal.
Oh, see, I'm like, I don't know how to say that word.
No worries.
Thanks, Heather. That's AKA throat and mouth. So HPV strains that cause genital warts are much less likely to cause cancer and vice versa. Estimated 1,300 cases of cervical cancer diagnosed in 2019 in the U.S. An estimated 34,000 cancers are diagnosed each year that are caused by HPV. So these are just some kind of updated stats. An estimated 14 million people in the U.S. become infected with HPV each year, and an estimated 79 million Americans are currently infected. So while I wrote this sweet article a long time ago, the information changes, and I want to just point this out as an opportunity and an idea for you all to do community engagement and to do outreach within your own communities. A letter to the editor is a really simple way to do that work. So you know what I'm going to say next? This work you are doing via PE46 touches on public health modernization in 3 ways. It addresses public health modernization capabilities via equitable access to health services, community partnership development via the public health modernization programs, as well as health equity and cultural responsiveness. This month's PE46 webinar, I think, really touches on equitable access to health services. So without further ado, we are going to talk about the HPV vaccine. And I am so pleased to welcome our guest speaker today, Dr. Stuart Decker. Dr. Decker is a family physician working in Klamath Falls with the Sky Lake Medical Center. He has a special interest in all things public health, believing firmly that the more things you can do to make a community healthier, the less unhealthy individuals you have to treat. Welcome, Dr. Decker.
Thanks so much for having me. Just making sure I have successfully unmuted myself, correct?
I can hear you.
Oh,
It's a great day.
Magic of the internet is a wonderful thing. Well, welcome to everyone. I was listening into the front part of this lecture, and I see that people are from all over. I also am perpetually impressed by the way in which the computers can make that picture of big and little words and continuously change it. I think we'll see that a couple more times during this presentation, but polling, man, polling changes teaching. Well, welcome. We're going to talk about the HPV vaccine. As you can see, the subheading, like just getting right to the quick of it, this is really about how to say, I'm not telling your children it's okay to have sex without actually saying those words. That's mostly what I've heard parents be worried about. There's a lot of speckles of other concerns, but that is one of the key features of how we talk about about the HPV vaccine. Okay, next slide. So I've highlighted, these are the things that I kind of want you to leave here knowing. So we'll start with just some fun facts about the HPV vaccine. These are things that you can bring up in sparkling dinner conversation or in your next clinic visit. There's some facts or some research about what the actual reasons are kids don't end up getting the HPV vaccine. I want to highlight that most of the time parents just trust you, and therefore you get to be confident in your recommendations because really they're looking for confidence. They're looking for you to know what you're talking about so that they can trust what you're talking about. The big thing in bold is bundling recommendations. We'll talk about what that means in a bit, but that's one of the key factors for high HPV success rates. QI, quality improvement, how to not have missed opportunities. There's some really cool data on herd immunity, so you can even talk about that with parents when they're trying to decide what or if or when to do this HPV vaccine. And then finally, some examples of how to respond to those parental vaccines. So we got a poll question coming up. This is the same style as before, but the question is, in one word, what is a common reason kids do not get the HPV vaccine?
Wow, this is fascinating. So the bigger the word, that means the more people are typing that word. So parents fear, look how big fear is.
Yeah. So once we get to about, I don't know, we'll get to 30 and then we'll just go to the next slide. Or maybe we'll get to 28 and we'll go to the next slide. So our next question, it's slightly different, and we might not spend much time on this one, but what are the parents' common concerns about the HPV vaccine? So I really like that conspiracy found its way onto there. Sex is obviously the big one that is the most poignant, and then of course safety coming up. There's a reason that we did these two different questions. So let's go to the next slide and I'll show you a cool study. This is just polling parents about why they did not let their children get the HPV vaccine. And there's some classic ones: not sexually active, not needed or necessary, safety or side effect concerns. But I want to pull your attention to the second one. We'll go to the next slide where it just highlights that it wasn't recommended to them. There is a good 13% of kids who are not getting the HPV vaccine because it wasn't recommended to them. So some of those parent concerns are like very good reasons kids don't get the vaccine, but one of the big reasons that kids do not get the vaccine is that it wasn't recommended to them yet. So we'll go to the next question. So, and what is the age in Oregon in which a patient does not need parent permission to get vaccinated? Great. Looks like we're battling it out for 15 and 16. The answer is 15. So that is the age in Oregon in which someone does not need parent permission to get vaccinated. The next question is kind of like a subheading to this one. Does Oregon law require written permission instead of verbal for those minors, for those 15-year-olds? Suppose this should be like a, oh, good. Okay, so Oregon law requires permission. It is a true-false question. I thought it was a yes or no question. You messed it up. You guys are right.
My apologies.
Oh, don't worry. You guys are right. We do not need written permission. Now, that is in Oregon law. There is no law stating you need written permission. That is global. Now, I would encourage everyone to know what their clinic or hospital system or public health system or county expects of you, just because those expectations can, in fact, be different than Oregon law, and you want to basically not get yourself in trouble by going. I think there's this philosophy that the specific overrules the general. So if in your specific clinic they have a policy stating that you do need written permission, either work to change that to adhere to that Oregon law at large, or just make sure you're doing that, make sure you're following the specific law while working to change it if you feel you need to. Next question is, what are the side effects? What are the actual side effects of the HPV vaccine? Now, I hope this is multiple choice. I hope it's multiple select, because definitely there's some more than one side effect. But great. Looks like everyone.
My apologies. I don't think, oh, maybe it is multiple.
One way or the other. No one is checking infertility, which I'm happy about. So we'll go to the next slide, and it will just highlight like the things that people get from HPV are the classic, anything that you would get from any other vaccine. So fever, headache, nausea. Some people will faint just if they can vasovagal out with a fear of needles. Those are all perfectly normal and frequent side effects of the HPV vaccine, but they're also side effects of any needle that you stick in your arm and then put fluid in. So you could get this practicing with saline as well. Okay, so next, fun facts. We're going to enter into our fun facts category. There's 120 types of HPV, which I thought was amazing. 80 of them cause cutaneous warts. So one great entryway conversation with parents is just the fact that if they know someone who has had a wart, then they know someone who has had HPV. This is wart on your finger, wart on your toe, wherever. This is caused by HPV. That's how common you can talk. And this is a good idea of how common this virus is. 40 of those causing mucosal pathology. Most of those are genital warts. Obviously, there's some that are high risk for cancers, which is what we're vaccinated against primarily. There are 79 million Americans currently infected. So remember that beautiful letter to the editor that was just brought up previously. I know that she highlighted the date at the top, which was 2007. So now in 2019, we have 4 times as many people who are currently infected. That is 25% of the adult population, or rather 25% of the total population are currently infected with HPV. 91% of cervical cancers are from HPV. That is the most. 91% of rectal and anal cancers are also from HPV. And then it goes down, but 70% of oropharyngeal is very significant. Interestingly, with that one, it is much more common in men. So there's been some studies that try to find out why. A lot of people hypothesize that it's the interaction between alcohol and smoking, or alcohol and especially chew, that really catapults men into the higher risk for oropharyngeal cancer. But definitely HPV plays a huge role in that, as it contributes to 70% of those cancers. And then really kind of poignantly, half of all cervical cancers are in women younger than 50. So this is a cancer of young women. 25% are in ages 25 to 39. So even more so, young women are really disproportionately affected by this type of cancer. Cervical cancer still contributes 4,000 deaths per year, which is just an incredible thing to talk about. So the next few fun facts. Oh, that's right, this slide. This is, I really wanted to highlight, this is a visual representation of which cancers are caused by which types of HPV, and then which ones are covered by the vaccine. So at the very top, you can see that the dark blue and the slightly lighter blue are those high risk types, and then those two are the ones that are covered by the 9-valent vaccine. So it is very true, and I think it's really powerful to acknowledge limitations when you're talking to parents. It's very true that the vaccine does not cover all of the HPV that causes cancer, but it covers the vast majority of the HPV that causes cancer. And then, of course, there are always some cervical cancers, some oropharyngeal cancers, some of all of these cancers that are not caused by HPV, but the vaccine does cover the lion's share of the types that contribute to cancer. Okay, so the next fun facts. 80% of sexually active people have been infected at some point in their lives. So just like Dolly talked about kids who are HPV positive after being born to an HPV positive mother, and then they usually clear that infection, the vast majority of people do clear the HPV infection. But I think it's important to note that at some point in your life, if you are sexually active, 80% of people will be exposed to HPV. So another little point in the favor of how common this infection is. And then this will really be poignant to all the mothers in the room with their children. 20% of women have had an abnormal pap smear. That means there's 3.1 million per year abnormal, which means that they have to get repeat pap smears or biopsies and colposcopies. So obviously right now we're minimizing pap smears as much as we can. We're doing HPV testing with them. If everything is negative, you don't need another pap smear for 5 years. And in my conversations with mothers or women who are having pap smears, people want to have those as little as possible, which I resonate with. It does not seem like a very fun thing to do. Pointing out that every time you have an abnormal pap smear, which is usually from HPV, or some HPV-caused pathology, you end up with a biopsy or a colposcopy or a loop excision. Those are procedures that are unnecessary if people do not have HPV. There are 62 million pap smears performed per year. Now, this one doesn't have as much hard data on it, but I have brought it out in some conversations. There's a couple researchers in Australia who hypothesize that if everybody gets vaccinated for HPV, we would no longer have to do pap smears, simply because the rate of cervical cancer would drop so precipitously that the benefit to risk ratio would no longer be there. Now, again, I don't have the hard data for that one. I don't think that exists yet, but it's an excellent thought experiment to talk about when talking with parents who are concerned about the HPV vaccine. So the next slide is showing a loop excision. So this is like, nobody likes to see a scalpel cutting into their cervix, but this is what you have to have as treatment for some of those types of cervical cancer or even pre-cancer. So this is one of the things that we can prevent and minimize by vaccinating for HPV. So how to start the conversation, just how to begin talking in a very positive and open way with parents of their kiddos during their well-person visits or whatever visit they have. So the thing that everyone is recommending is same way and same day. Same way and same day means that Tdap and meningitis vaccinations are also due at age 11 and 12. So recommending the HPV vaccination in the same way and on the same day is considered a bundled recommendation. So I put this in red, but if they don't interrupt you to ask more about the HPV, you don't need to say, now hold on, just so you know, one of these is controversial. Would you like me to talk to you about it? If they don't have concerns about it at all, you don't necessarily need to create concerns for them. So the next slide is an example of a very brief way you can talk about it. So your child is due for 3 vaccines, 1 to prevent tetanus, 1 to and pertussis, 1 to prevent meningitis, and 1 to prevent cervical and oral cancers. That is a very brief way of talking about it. The next way is a little bit more fleshed out. So the next slide is, she's due for 3 important vaccines. The first is to help prevent an infection that can cause meningitis, which is very rare but potentially deadly. The second is to prevent a very common infection, HPV, which can cause several types of cancer, including, and then this is where I would interject with cervical cancer, penile cancer, or oropharyngeal cancer, depending on, say, the gender of the child. The third is the tetanus booster, etc. We'll give these shots at the end of the visit. Do you have any questions for me? So you really can adjust this bundled recommendation to your preference for how much you want to talk about it. The key really is they have found that as these vaccines are offered in a bundled, like as a bundle, these are your adolescent vaccines, people are more likely to go for them. Next slide. This is one of my favorite studies. Now, of course, the way this works is the first slide is researchers asked parents to place a value on vaccines. They say, all right, out of 10, with 0 being none and 10 being the most valuable thing or very valuable, how would you rate your value of these vaccines? And you can see over on the right-hand side that HPV and adolescent vaccines and influenza are all still in the 9, like above 9 on that rating scale, which is very reassuring to me. Like, I think we all have that. We all have that ability to remember those parents who are very angry at us or very opinionated or very worried about the vaccine or something like that. But those truly are in the minority of parents. And we have data that can reassure us that most parents are fine with these vaccines. The next slide shows...
Doc,
yes,
can I interrupt you? We have a question.
Oh, a question.
Yeah, it's so exciting. If a pap smear is abnormal, could you also test the sample of PCR DNA HPV to avoid a biopsy colposcopy?
Yes. So in my pap smears, I test for both cell atypia and then we test for HPV. And then if the HPV is positive, we have a reflex send out to tell what type of HPV it is. Now, your next step depends on what those results are. So for example, if it's like cell atypia, but there's negative for HPV, you just do another pap smear in a year. If it's high risk type of HPV, then you have to do a biopsy or a colposcopy. If it's both, like there's a really beautiful decision algorithm tree that just tells you exactly if it's this type of HPV and it's negative, you do this. If it's this type of HPV and the cell atypia is present, you do this. If it's this type of cell atypia but there's no HPV, you do this. But I think important to note is that if there's any sort of atypia, whether it's cell atypia or HPV positivity, your answer is never going to be, oh, you're good for 5 years. At the very minimum, it's usually repeat pap smear in 1 year. And I think that probably that's punishment enough. I would say that that's worse than having to come back in 1 year is worse than 5 years, no matter, like, it's definitely better than a biopsy or a colposcopy. But if there is something atypical on your pap smear, the very minimum that would have to happen is coming back early for your next pap smear. Does that answer the question?
Yes, it says there's also an app that has the algorithm built into it.
Yep, yeah, so that is a very useful app. I can't remember the name of that app right now because I have it like saved on my desktop, so I just pull it open. But if that person who knows that app can share that with the group, they can definitely look it up. From what I remember, I think it has a charge to it. I think it might be like a $2 app or a $5 app. I might be wrong, and maybe that's changed in the last few years. But I do find
the name of the. She says the name of the app is ASCCP.
That's
A is in apple, S is in Sam, C is in cat, C is in cat, P is in Pat.
Yep.
or Paul.
Yeah, and I think that it stands for something like the American Society of something, 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 but they do make a good app.
American Society of Colposcopy and Cervical Pathology.
Yeah.
Thank you, Jessica Nye.
Beautifully done. So if you are a person who is doing pap smears, which you very well might be, maybe take a look at downloading that app. again, the algorithm it just makes it really easy. There's it's very easy to follow. And unfortunately, if there is an atypical result, usually the minimum is that you're going to have a more frequent pap smear. Okay, so back to the slide, I think. This slide, so you can see the lighter blue next to it. This is the clinician's estimate. This is the clinician's guess of what the parents estimated. So this is clinicians, what do you think the parents said about their value of the vaccine? So for meningitis, hepatitis, and pertussis, we're right on. We think that parents think that they're valuable. But in the next slide, you can see that we providers totally underestimate how much parents value these vaccines. So it is a stark difference between 5.2 on that value scale, which is what we guess parents say, and 9.3, which is what actual parents do say. So I had included this just to give you a little bit more confidence when you're talking about the HPV vaccine. Not all of your conversations are going to be fights. I think that that's something that I was fearful of when starting to talk to parents about HPV vaccines more frequently. But most of the time, if there's a question, it's truly that, a question. And if I know the answer to the question, it's pretty straightforward and easy. Really, parents do value vaccines, and they do value the HPV vaccine by and large. This is just the next slide is just to remind you that a big chunk of people are not getting the HPV vaccine, not because of an actual concern, but because it wasn't recommended to them at whatever visit they were at. So those two things have been really helpful to me. One being reassured that I don't need to be fearful of a fight every time I talk about this vaccine. And then two, knowing that a huge chunk of kiddos don't get the vaccine simply because it hasn't been recommended to them has really been empowering to me in my practice. Okay, so next is how to finish the conversation. So you started it with your bundle. Many people will just accept the bundled recommendation, and if they don't, they likely just need reassurance. Like I said, most times the question is just that, it's a question. Sometimes it's not, so it's I want to acknowledge right here that there's some people who really do think that there's conspiracies, and people who think that, and who are like dead set against it. And I want you to not beat yourself up about it because that does happen. When they just have a question, I think it's always important to just ask what a specific concern is. It's flu season. I've been doing this a lot with the flu vaccine, and a lot of times people got the flu shot 15 years ago, and they had one of the live vaccines, and they got sick from it somehow, and they think it's all the same now. So it might just be a case of new information that they don't have. It might be a case of they have a concern about something they heard and they want you to answer it. So as long as you can respond knowledgeably to that specific concern, a lot of the time you'll just be able to address the concern and proceed with the vaccine. I really like to highlight here that it is not a good idea to give them reasons to be concerned. So maybe if they say no, don't try to guess, oh, did you hear it? Are you worried because you heard that it kills kids in England? Because you shouldn't be worried about that. And sometimes like, well, no, I hadn't heard that, but now I'm worried about it. So ask first what their question is before trying to answer all of the potential questions. So to recap, some of those really beautiful fun facts can come back into play here. So I just wanted to highlight some of them. 80% of all sexually active adults in the States have been infected or have been infected at some point in their life and have mostly cleared it, but 80% is a huge number. I like that it is the same number as 80 million currently infected, which is also a huge number, and just the math again is 25% of the US population. It's responsible for 91% of cervical cancers, kills 4,000 women. It's cancer of young people, which is really, I think, impactful for a lot of parents. And then lastly, that pap smear question, I think, is really important. Parents of young girls really, I imagine, can have a lot of empathy and a lot of desire to minimize that procedure, that test for their children. Okay. Next question, our next concern that might come up is, does my boy really need it? The answers that I have to that would be pap smears. If a boy gets his HPV vaccine, then he will minimize all of those extra pap smears for potential future partners. Also, we have that very generous hypothesis that if we get everyone vaccinated, we won't need them at all anymore. I think the data definitely supports the idea of with more HPV vaccinated youth, less people will have those colposcopies, those repeat pap smears, those biopsies. And then just to refresh, the oropharyngeal cancer is 5 times as common in men, and then 70% of that is due to HPV. So next, why so young? So there's 2 answers to this. First, your immune system does create the strongest immunity when you're younger. So as a reference point, if you start the vaccination series after your 15th birthday, it's 3 shots, not 2. That's not to punish people who are doing it later. That's simply because it takes more shots to create the same level of immunity. So as you're younger, your body is creating immunity a lot more and a lot more efficiently. So that's really why we start young. And the second thing is it's a lot like your seatbelt. You put it on before the car accident. Now, I've given some other talks in which some like the people who created the talks recommended asking like a question of, well, it's like a seatbelt. Would you put that on when you leave your driveway, or right when you see the car coming at you, or after you get hit in the accident? And I feel like that's a little condescending to ask in that multiple choice kind of way. It's a little paternalistic, but I do think that the prevention message does hold. And I think that that's worth bringing up, is just like, it is a preventive measure. This is definite, I fully agree. Your child is not having sex at 11. Now, I have had kids who are having sex at 12 and 11, but you want to reassure the parents and say, your kid is not having sex at 11. Also, we want to make sure this happens before they get exposed. Okay, so question. I'm worried it will seem like permission to have sex. So I've come up with some ideas. I would love to I don't know, hear some sort of discussion, or I think later we have some poll questions about it. But some ideas on how some of my colleagues have responded to this big, more common, very frequent question. So one, giving children the chickenpox vaccine doesn't feel like permission to bring them to people with chickenpox and rub up on them, right? If you make it clear that something is a bad idea, no amount of protection from it will seem like permission. That is a philosophical type argument, trying to create an analogy between a different vaccine with a chickenpox vaccine. So we used to have chickenpox parties in which, if my neighbor had chickenpox, my mom would bring me over to contract chickenpox so that we could just get it out of the way in a controlled manner. Now, if my neighbor had chickenpox, I wouldn't bring my vaccinated child over to there to rub on them, because it's A, is unnecessary. It's unnecessarily dangerous. So it doesn't seem like a good idea just because I'm protected. So that's a good example that you can use. The second thing is HPV is not the biggest, quote, risk associated with sex. Pregnancy is. So the reason I bring this up is that I want to encourage parents to talk about sex, and therefore have conversations, so that they know that protecting from HPV is not protecting them from the greatest risk of sex. So I'm not going to get HPV is not a great reason to go out and have sex. If kids are appropriately or educated sufficiently about sex, they should know that HPV is not the only risk they're facing when engaging in sexual activity. They are at risk of sexually transmitted infections, or at risk of pregnancy. And those are the risks that I really want parents to be focused on. And then finally, kind of as a throwaway, but people have studied this. There's been dozens of studies showing that there is no increased sexual activity among vaccinated youths. So the idea of maybe my kid is going to feel like there's permission now because they have this HPV vaccine, one way or the other, cohort studies are showing that there's no actual increased sexual activity. So that is that answer.
Okay, we've got another question.
Ooh, good.
Or comment, rather. It says, I've read that to get the best immune response to the HPV vaccine, is to begin at age 11, 12, and that there is not a positive, as positive of an immune response if given at 9, 10. So it's a question comment.
What I know is that the recommendation is definitely at 11, 12. I have not yet given it to a 9 or a 10-year-old. I know it's allowed. I know it's FDA cleared. I have not read that specific study about whether it's less effective at 9, 10. Have never recommended it then, only because I don't recommend Tdap and meningitis then, and I do recommend them all as a bundle. So,
Dr. Decker, do you mind if I
jump
in here real quick? Okay, this is Heather. I'm the HPV prevention coordinator for the immunization program. We do know that 9 and 10 does not have less of an immune response given at 9 and 10 compared to 11 and 12. It's still a very strong, robust immune response at that age. In fact, the American Association of Physicians, AAP, has actually recommended, they have broken with ACIP and recommended that doctors start providing it at 9, just because it gives more opportunities to get that kid vaccinated by the time they're 13. So yeah, just wanted to note that it is not the case that it is less effective at 9 or 10.
Wonderful. Good addition. Okay, any other questions or comments on the previous slides? We'll take a pause to let people throw some questions or comments in. Haven't been pausing sufficiently.
Okay. No other questions.
Beautiful, great. So the next question, the next Q&A that I often get is, does it actually work? So to tell if it actually works, we look at 3 different places. We look at short-term outcomes, long-term outcomes, and midterm outcomes. So I said those in a weird order, but short, mid, and long. Short-term would be genital warts and just prevalence of HPV. Midterm is the basically pre-cancers, and then long-term is the actual HPV-associated cancer prevalence. Now, because the HPV vaccine came on the market in about 2006, I don't really know. No one expects to see long-term outcomes yet. We do expect to see short-term outcomes and some midterm outcomes. So on the next slide, we can show you a couple of graphs that highlight some beautiful short-term outcomes. So these are complicated. I'll walk you through them, but just on the left slide, on the left graph, you see females in Australia. So the people who were the green solid line is less than 21 years old, and these are people who were vaccinated. And then the red dotted line is also people who are vaccinated. The green dotted line is people who are unvaccinated. So you can see the proportion of females diagnosed as having genital warts decreased significantly after the introduction of the HPV vaccine at 2007. The proportion of women who are not vaccinated did not change their rate of diagnosis with genital warts. So that basically tells us that the HPV vaccine is providing a decreased rate of genital warts in females who are vaccinated. Now, the next slide over on the right really does show something interesting, which is just that men were not vaccinated in Australia for this study, but we did see some herd immunity. So as soon as HPV vaccine was initiated, you can see this significant drop in essentially all of the groups, none of whom were vaccinated. So I do want you to know that if you're doing this work on HPV and you're maybe 80% successful, then you are still having some herd immunity on the rest of the population. So pat yourself on the back, herd immunity is working for us. The next slide is some other short-term outcomes. This again is a little bit of a complicated slide. I'll explain it as best I can. But it is shown, it's the prevalence of any HPV, like number 1, let's just focus on 1, 2, and 3. Number 1 is any HPV. Number 2 is any non-vaccine type HPV. And then number 3 is vaccine type HPV. And then the 3, like 1, 2, 3 is essentially young people. 5, 6, 7 is middle people, like the same grouping as in Australia, where it's just like less than 21, 21 to 30. And then the 9, 10, 11 is people older than 30. So what they wanted to show is that in the 1, 2, 3, there's no significant change in prevalence of any HPV. I mean, there's a little change, but it's not graded as significant. And then non-vaccine type high-risk HPV, there's no significant change. And then there's a 64% decline in vaccine type HPV. So this is all about the prevalence of HPV, and it's showing really poignantly that the vaccine type HPV is declining while non-vaccine type HPV is not declining. So showing that there's not some weird global decrease in HPV, it's just purely the HPV vaccine types that's showing a really big decline. And then in the people who are over 30 in that 9, 10, 11 range, over on the right side of the slide, there's no changes in HPV prevalence at all, including for the HPV, the vaccine type HPV, showing that people who are not vaccinated do not have a declining rate of prevalence of vaccine type HPV. So short-term outcomes, we have both decrease in genital warts and decrease in HPV prevalence. The next slide just summarizes a couple studies in countries with greater than 50% coverage. So this is 9 high-income countries. The prevalence of HPV 16-18 decreased by 68%, and then anogenital warts decreased by 61%. So if someone asks you, does it work? You can say, yes, we have very good data for short-term outcomes. So if they ask you if they've seen a decrease in actual cervical cancers yet, you can say no, but also that we don't expect to, because it's only been about 10 years that we have data from. We do have lots of data showing that there's decreased HPV prevalence and decreased anogenital wart prevalence. The next question is it safe? So are there side effects, et cetera? So point 1 is that there's no actual virus in the HPV vaccine. It's all virus-like peptides. So there's no, they didn't like even chop up HPV virus. There's no actual virus. So that's oftentimes reassuring to parents. They should also know that there's 4 different types of reporting agencies in the states to report side effects for vaccines. All of them are at different levels. All of them are like, there's governmental, there's non-governmental, there's just lots of people tracking vaccine side effects, and none of those 4 different reporting agencies have shown any increase above baseline for negative outcomes. So that's an important distinction right there. It's just that the HPV vaccine is getting, or has a lot of publicity for CIDP and chronic inflammatory demyelinating polyneuropathy and neuropathy and autism and these other kind of terrible side effects that people are worried about. I think it's very important to note that people do get those things. Like those things happen in the baseline population at a certain percentage rate. And then the HPV vaccine does not change that percentage rate that those things happen. So people still get bad nerve damage. People still get seizure disorders. People get sudden death. But those happen at a prescribed rate in the population, and HPV vaccination does not change that rate. It also is important to recognize that there are side effects. So whenever I'm giving someone a vaccine, I always talk about injection site reactions, fevers, headaches, fainting, soreness where the arm is given, just so that it doesn't feel like I'm ignoring concerns or swiping anything under the rug. I just like to tell people what they can expect. And then if they have some of those specific concerns, really trying to address the fact that those things happen to kids at a certain rate, and that rate doesn't change based on vaccination. The next is, why isn't it required for school? The short answer is simply that people who create school requirements are not public health officials. It's recommended by the CDC, pediatric, adolescent, OB, and family medicine groups. So we have a lot of physicians and public health specialists who do recommend it, and then it just hasn't filtered into the school requirements. So depending on the political leanings of your patient, you might want to bring up Betsy DeVos and ask, do you want her to be deciding what vaccines your children get? Do you trust her judgment? Or if it's just, do you want the government you want to trust the government's judgment on what vaccines you should get? Just, you can, if you know your patients, you can try to bring up some of those who do you trust kind of questions. Next is, does it cause infertility? And the answer is no. Participants are perfectly fertile 12 years later on, if they want to be. They don't have to be. But there is, same thing, cohort studies that show that if people want to be fertile, they are exactly as fertile as everybody else in their age-matched cohort. Okay, and then how to restart the conversation. So if they've already gotten the 11 and 12-year-old shots and they're back for their 16-year-old well child visit, or they like declined it the first few years, really, I always start with, it looks like you're due for this. Do you have any questions about that shot? I think that I have always had good luck with, do you have any specific questions about that? And it opens up a conversation. If I'm alone with the person or if I'm with their parents, one way or the other, I usually try to start the conversation. And I've really given myself permission to walk away from someone who is really angry or upset or adamant about not getting it, and not trying to beat myself up for not succeeding and giving them that shot. And part of that's knowing that herd immunity does exist and really does work. And part of that's knowing that there are just some people on the spectrum who are so far into the, I have convinced myself and I'm sure about my answers that nothing you're going to do is going to change their mind. And I give myself permission to not be sad about those.
Dr. Decker, I just want to give you a time check. We have about 4 minutes left in this webinar.
Okay, we'll go fast. So restart the conversation. We talked about the herd immunity. That's the next slide. The next one is the missed opportunities. Just that if you look at basically other vaccine types and their like prevalence and vaccination rates, and then HPV vaccination rates, we know that there's a lot of missed opportunities that we're getting in terms of how often we could be offering the HPV vaccine. So if you go to the next one, you can see it's a complicated slide, but at the very top you have tetanus. So tetanus is approaching 90% prevalence. People are getting the tetanus vaccine. But that first HPV shot, which should be offered at the exact same visit, has a much less or lower pickup rate. And part of that is parent concerns, part of that is all the things we've talked about, part of that is not offering it. So next slide. Missed opportunities. This is just things that you can do with quality improvement to try to improve your vaccination rates. So do you have an electronic health record? If you do, there are some really cool ways you can create templates. You can have automatic pop-ups. I've edited all the templates for my hospital system to include a hard stop for, do you have the HPV vaccine? Do you have any questions about it? Does your rooming staff, so people who are rooming your patients, do they talk with them about the vaccines before the provider gets in the room? That's something that they might be able to just pre-game for you. Do you have standing orders for giving vaccines whenever desired? So I have patients who will just walk into the office and say, can I get this vaccine? And they never see me because we have standing order that says if someone walks in and gets this vaccine and they meet these requirements, like don't have this allergy, haven't had a vaccine in the last 28 days, et cetera, they can just get the vaccine. Missing vaccines at any visit, so my electronic health record warns me if they're missing anything, but even if you don't have that at any old injury or same-day visit, you can always ask and look to see if they're missing any vaccines. And then we always print a gap list. So a couple times a year, we'll just run a report saying which of our 12 to 18-year-olds or which of our 12 to 26-year-olds do not yet have the HPV vaccine, and then we can just call them and ask them if they want to come in and talk about it. The last couple of slides, this is a poll question about the Merck Patient Assistance Program. This is cool. I'll just talk while people are answering this, but apparently Merck will offer free vaccines for people who meet certain eligibility requirements. The next slide shows those eligibility requirements, so I'm sure you can have access to those, but generally it's uninsured, over 18, and then a certain income level. But basically Merck just give you, your office buys the first crate of vaccines, and then you, when a patient comes in who meets that criteria, you can just give them one, and then Merck will mail you a replacement one. So you can have an infinitely replacing vaccine supply box that you just need to know these eligibility requirements and get in contact with the Merck people. Now, that might be a clinic administrator kind of job. That might be not something that you know what to do, but if you tell them about it, or they won't know about it until you tell them about it. So that's a great opportunity. And then community outreach, just like Dolly talked about earlier, write a letter to the editor of the local school paper. Doc in a Box at school carnivals. I've been doing lots of school carnivals recently and have fielded lots of questions about the HPV vaccine from parents. Parent-teacher conferences, I've been reaching out to schools to see if they want to have a doctor at a parent-teacher conference to just answer questions there too. And then we have a school-based health center here in Klamath, which is awesome, and they do vaccines, but that could be an opportunity for a big infrastructure change. So the last slide is just, has anyone had success with blank? Ooh, group visits is on there. I do group visits for some things. I do group visits for diabetes and blood pressure, and we'll be starting group visits for vaccines in the coming months, at least for vaccine questions. And those are going to be less frequent, but available to parents.
Thank you so much. So we have one question that we will wrap up with. And Allison, can you read it out loud to us?
Does the Merck Assistance Program work for all vaccines? So this Merck program is, oh, sorry, go ahead, Dr. Decker. You can get it.
No, I don't know the answer. I think you should answer it.
The Merck has patient assistance programs for other medicines that they provide, but I have not looked into them. So I know that they have this Merck patient assistance program for Gardasil 9. If you go on their website, they have a very easy to navigate website that tells all of the different products that they provide this for. And if you're worried about other vaccines, you know, look for those manufacturers. A lot of the manufacturers do have patient assistance programs.
All right. Okay, this is the information for the immunization program. If you have additional questions or resource or need more anything, you hit us up. That's the immunization page. This is reproductive health. This is the first time that we have partnered on a joint immunization and reproductive health webinar. We're really excited about it. We really thank Dr. Decker for sharing all your wealth of knowledge and information. Everyone have a wonderful Friday. Thank you. Thank you, Dr. Decker.
Thanks for having me.
Take care, everyone.